Okay, hello everyone. So this is the second video of the principles of patient assessment. The focus of this video is about patient history. Okay. Patient history is relevant to any practice setting. In order to do any assessment, you need to take patient history. And it's very important to any assessment occasion. And the history could be focused, like minimum information in order to do a focused assessment, or it could be a comprehensive history that could be used. And it includes two parts: the patient history, the health history, and the medication history. Okay? So the health history includes patient demographics, so patient age, height, and weight, body mass index, and so on, history of the present illness, chief complaints, why the patient is here, past medical history, family history, social history, also includes review of systems, and this we'll talk about the physical examination as well, lab findings, and other investigations and diagnostics. So the past medical history is the list of the patient medical conditions and problems. And it's better when you list the patient medical condition, you need to know for how long the patient has been having these conditions, dates and duration. Hospitalizations, surgeries if there's any relevance, accidents and injuries if relevant as well. So asking about hospitalization, so like multiple hospitalization for pneumonia and COPD patients. This could be a sign of uncontrolled or severe COPD, as an example. Okay, so once you have the patient past medical history, you can use what we call problem-oriented medical record system. And this medical record system includes two things: the problem list and the DAB note, like a documentation. What's the problem list? Problem list is the patient problems that's actually current or temporary happening, and these are not the drug-related problems. Drug-related problems are different. We'll talk about that in the fourth video, but the problem list is the patient problems that's currently having, and these problems could be permanent problems, and these permanent problems could be active or could be inactive, or could be temporary problems. Like, for example, I had a sore throat 2 days ago, so this is considered temporary problem. If someone had for example, constipation 3 years ago, but it didn't happen again, that's a temporary problem, right? Do you include them in the problem list, the temporary problems? Most likely no, because they are temporary, unless it's becoming chronic, like multiple bouts of urinary tract infections, for example, and so on. So let's have an example here. 17 male, and the question for you is there temporary problem, permanent problems, or include them or not. Okay, so if the patient had appendectomy in 1967, is it temporary or permanent? When you think about it, like, you can pause the video and think about these issues. So appendectomy is permanent because the patient does not have appendix anymore, right? But it could be an inactive issue. So you can include it if it's relevant, but if not, you might not be including it. Hypertension 1993, and the patient is still hypertension, as like having high blood pressure, or maybe it's under control, but still, it's a permanent problem, and probably it must be included. Patient had a sore throat in 2016. No, I'm not going to include that unless the patient has ongoing sore throats for some other illnesses. Wrist sprain 2010. So it's a temporary, I will not include. Heart failure. Yes, it's permanent chronic illness, and you must include. Sulfa allergy, hives. Yeah, it happened to the patient in 1985, but it's something that must be included, as you know. it's a long time ago, maybe you can need to do an allergy assessment to check if that actually is true, is actually the patient still allergic to it or not. DM2, diabetes, type 2 diabetes, yeah, it's a permanent, you need to include. Constipation 1975. If the patient is still having constipation, yes, you need to include, but if not, and if it's not chronic constipation, you will not include. But if it just happened because of reduced fluid intake in 1975, I'm not going to include that. Okay. Hopefully, like now we know now we will be able to write the problem list for any patient you take history from. Other pieces of history, health history, the family history, asking about illnesses of first-degree relatives, and if they're living, and the causes of death and age. Attention to the stuff that could be having some hereditary linkage. Attention to heart diseases, hypertension, hyperlipidemia, diabetes, cancer, osteoporosis, alcoholism, and mental illness. Social history, ask about the alcohol intake, tobacco use, illicit drugs, consumption of cannabis as well. Nutrition and exercise is something it's important to ask about, and because maybe actually the pharmacological management could be the answer to the patient problems. Non-pharmacological management, I mean. Okay, so ask about social history, if the patient is taking balanced meals or not, how often the patient is exercising, what type of exercise the patient is doing. Okay, after collecting these pieces, you can do review of systems, and this is to identify abnormalities or issues which may not have been identified by the patient. Okay, each body system is reviewed, often in a head-to-toe sequence. And depending if what type of history you're taking, is a focus history versus comprehensive, you might not ask for all these questions, you might not actually check those, all of them. A review of system can be completing using the following: by focused questioning, open-ended with closed-ended questions, information gathering from other healthcare professional notes, like for example, patient saw the doctor this morning and did a physical exam, you can collect that from there, or you can do your physical assessment yourself, depending on the practice setting, right? Big list of review of systems, and starting from head to toe, so the heads and eyes and ears, and until endocrine system, reproductive system, hepatic and renal, urinary tract, gastrointestinal, and there are many symptoms could be associated with each system. Okay, and it's important when you're doing the head to toe to make sure you are covering what's relevant to the setting that you are having. That's happening, like why the patient is seeking care, right? Okay, physical assessment. Physical assessment is the evaluation of the objective anatomical findings gathered through 4 activities: inspection, by just looking, palpation, touching, percussion, and auscultation using the stethoscope. Pharmacy practice can be enhanced with the use of physical assessment, and it's useful for initial and follow-up assessment of patients, useful for monitoring response to therapy and adverse drug reactions, and also for identifying the red flags. Okay. The sources for physical assessment is documentation by other clinicians and completed by some pharmacists as well. Physical assessment could be overwhelming. It's science on its own. And it's the most important one, the take-home message. It's important to understand the meaning and how the meaning of the physical assessment finding and how they are related to the drug therapy. Okay? And the simplest way of physical assessment is measuring blood pressure. Understanding the meanings of the blood pressure value, if it's controlled or under control, is very important, right? And you need to focus on relevant physical assessment findings that actually relevant to your setting. Not every pharmacist can do it, but like some pharmacists actually can do physical assessment depending on the practice setting. But there are two main ones that actually could be useful to most pharmacists. One of them is the general survey. So the general survey is actually by looking at the patient appearance, behavior, and mobility. So when a patient comes to your pharmacy, or comes for a medication review, or come to your pharmacy for a refill of prescription, you can actually look at the appearance, behavior, and mobility. This is some sort of inspection without actually touching the patient, right? So like by looking about the overall appearance of the patient, the hygiene, grooming, the patient attire, skin color might indicate some illnesses like jaundice, it's yellow colored, right? Presence of lesions, patient height and weight, like the patient is overweight or underweight, behavior like facial expressions, level of consciousness could be a sign of red flag if the patient has low level of consciousness, orientation, speech, demeanor, mobility as well, patient posture, range of motion, is the patient using mobility aids, and gait. Physical assessment, also one of the easy pieces of physical assessment is doing vital signs. So, and the vital signs, there are including blood pressure, pulse, respiratory rate, temperature, and oxygen saturation. So many pharmacists can do blood pressure measures, right? You can check the pulse of the patient. By checking the pulse of the patient, you can check the rate and the rhythm. Not only the, like if it's how many beats per minute, and it's actually, is there any signs of arrhythmia? You can actually, if they are regular or irregular. For example, irregular beats may be a sign of arrhythmia or atrial fibrillation. So probably this warrants further investigation by the patient. Respiratory rate, temperature, and oxygen saturation. Okay. Okay. For example, this is a table presents the normal vital signs for adult patients. Like blood pressure, systolic blood pressure is 120, 140. Diastolic blood pressure is 80 to 90 millimeter mercury. Heart rate is 60 to 100 beats per minute. And temperature is varies by the measurement method. Generally range between 36.1 to 37.2. Respiratory rate, which is 12 to 20 breaths per minute, and oxygen saturation generally is more than 90%. Okay. So physical assessment, like how to perform blood pressure, vital signs, the respiratory rate, pulse, and other physical assessment findings. These are some resources that are very helpful. One of them, the chapter 3 in the patient assessment in clinical pharmacy, a comprehensive guide. It's about physical assessment for pharmacists. Bates guide, visual guide to physical examinations. It's very helpful. It contains lots of videos on how to perform physical assessments. And also there's a textbook by Jones, Patient Assessment in Pharmacy Practice. It's very helpful and contain information about details of physical assessment. Okay, lab values. So lab values, this the patient values that you can find, and by looking at the lab values starting from white blood cell count to ALP. So first, before I go over that, I have a question for you. So I want you to pause the video and look at these lab values and tell me if they are good, and or if there's something you notice that warrant further investigation. Okay? Okay, so if you pause the video and looked at it, you will notice that all of these lab values are within normal limits, with the exception of hemoglobin A1C, right? And it's 8.8%. So if the patient is not having, is not diagnosed with diabetes and presents with hemoglobin A1C of 8.8, this like a value that's worth further investigation. So maybe the patient has diabetes and doesn't know, right? So that's an important function of the lab values when you are doing a medication review. Also, if you are looking at any adverse reactions of medications, looking at these lab values are very helpful as well. Okay, but another question for you: do you need anything else? Are the lab values good? Let's say hemoglobin A1C is good. So if you are reviewing them and saying, oh, well, lab values are good, right? And they're good to go, no concerns, right? Not really. Why? Because if you look closely, you'll see these lab values are missing serum creatinine. And if the patient on a medication that needs renal dose adjustment, or if the medication is nephrotoxic, probably it's worth looking at to serum creatinine, right? But it's not given to you, right? So that I'm telling you that lab values could be overwhelming data, and when you're looking what's normal, what's abnormal, this is great. However, before looking at lab values, you need to think about what lab values do you need to see in order to assess the patient properly. Okay, that's important. Ask yourself a question first before looking at the lab values. Okay. Lab values are very helpful in patient assessment. You need to know what to look for, as I said. The trend of the lab value provides more info than the actual value. For example, if I tell you today patient serum creatinine is 150 micromole per liter. So 150, oh, that's going to be a little elevated, right? But if I tell you yesterday the patient's serum creatinine was 200. So now when you're thinking of the trend of this lab value, what 200 becomes 150. Now the kidney function is improving, right? But if yesterday was 75, let's say, oh, the serum creatinine got doubled. Patient might be experiencing AKI, acute kidney injury, but of course, you need other variables in order to assess if the patient has AKI, like urine output, for example. So the trend of the lab value provides more info than the actual value. Lab values frequently applicable to pharmacy practice: the complete blood count, CBC, with or without differential, serum electrolytes, sometimes refer to them as lights, urea, serum creatinine, liver function test, ALT, AST, bilirubin, INR, alkaline phosphatase, and albumin, TSH, drug levels if of relevance, microbiology as well if there's any relevance to that, blood and urine cultures, and so on. Okay. Other investigations and diagnostics: chest X-ray, bone mineral density, ECG, EEGs, and many more other investigations. It's important to understand the findings of those and how they are relevant when you are assessing medications for your patients. So it's important to understand the meaning of these. You don't have to be an expert reading chest X-ray, because done by radiologists and MDs, but you need to have an understanding of the findings of the chest X-ray. Okay, medication history, which is we are the drug experts, so you need to look at the patient current prescriptions, medications, the patient actual dosing schedule. Like if you have it in the list, it doesn't mean the patient is actually taking those medications, so the actual medication. If the patient experienced adverse drug reactions from it, patient allergies, any past medications that could be causing problems currently. For example, lithium can cause problems even after you stop it. Non-prescription medications. When you're looking at the non-prescription medications, you need to see if there's any herbals, any inhalation, any other stuff over the counter the patient is taking that might affect the patient medication and health. Any PRN medication the patient is taking, and the important thing, quantity. Like for example, like if the patient takes 1 NSAIDs every while, it's way different, way significantly different if the patient takes 5 tablets a day, right? So it's important to know the quantity of the PRN medication to get the history. So again, finally, so medication history, patient current medications, previous medications, PRN medications, and the quantities needed with actual schedule, and also non-prescription medications and herbals, and any supplements as well. Okay, this is in addition to the patient allergies. And the most important piece here, accuracy. When we are documented, you need to be very accurate regarding for the name of the medication, the dose, frequency, and route. And this marks the end of this video, and see you next time. Bye.